Hello everyone, welcome to this second Vulval Pain Society social media live. And if you're watching the replay, hello and thank you for joining us. This second social media live from the VPS will focus on gynecology and pain clinic appointments, how to prepare and what to expect. I'm Sheren Gaulbert, trustee of the Vulval Pain Society. I'm a bit of a pain geek, pain science geek, and also a practicing therapist. With me today are my fellow trustees, David Nunns and Winston de Mello. And I'm going to add them so that you can see them. So let me just add them both. Hi, Winston. Hi, David. So hi to everyone. We're live.
Hello. Good evening.
Good evening, everyone.
And of course, it might be evening if they're watching live. It might be morning or afternoon, depending if they're watching the replay. Thank you, whatever time you're watching us and wherever you are in the world. David, we're just going to jump in and we're probably just going to open up a bit of a conversation, really. We've got a number of questions and Winston, if you feel like jumping in when David's chatting, feel free to interrupt. And vice versa. David, you're a consultant gynecological surgeon and clinical lead of the Vulval Health multidisciplinary team at Nottingham University Hospital's NHS Trust. Have I got that right?
Yes.
Fairly accurate?
Yes.
We talk about multidisciplinary teams and multidisciplinary care, don't we? This mix of therapies that might help the unique individual, and that mix is going to be different for each person. And often the entry point to the wider multidisciplinary team is via a gynecology clinic appointment.
That's right.
And those pre-multidisciplinary team appointments can be pretty short. And I remember you saying sometimes even as short as 20 minutes. So using the time wisely seems absolutely vital. So preparing beforehand, getting what needs to be said is really important because it's a short appointment. On the Vulval Pain Society website, we have a pre-clinic questionnaire. There's a diagram where you can mark out where you might be experiencing pain. The questionnaire is pretty long. We'll put up the link to access that later on. But let's pick up on a few points. You mentioned that it's important to jot down and have ready a short list, a list of medications that have been tried, dosages, previous treatments, maybe healthcare professionals that have been seen, and the responses that patient has had to these things. Why is all of this important, and how does it help you?
Yes, so you're absolutely right. These appointments are quite precious. I would say for a general gynecology outpatient appointment, you have 20 minutes. There would be less time for a follow-up. Now, in that time, 20 minutes, you've got to take a history, an examination that includes getting dressed, getting undressed, and then explanation. It is a very short period of time to cover what might be very complex. And I think the key thing is for us is to take a history examination, arrange appropriate tests, and make a diagnosis. And that's the first part of the hurdle, getting the diagnosis, because we have to do an examination to get a diagnosis for a woman with a vulval problem. So you've got potentially in the history a lot of past treatments that have been tried with or without effect, and some of these treatments may have been used suboptimally. So that element of the history does take time. Then you've got the examination to find the cause and then come up with a diagnosis. So that's very important. That's what we do as doctors, making a diagnosis. and often people haven't got a diagnosis, and that is a problem. And then you've got the other type of consultation where somebody has got a diagnosis and they're coming for a management plan. That might be a follow-up visit, or that might be a second referral. So to answer your question, I think the pre-clinic questionnaire form we've got, or it can be any sheet of paper, it could be any questionnaire. I mean, it should produce some summary of the treatments that have been tried, how long they were tried for, dosages, side effects, benefits or not, is all very helpful. And I get this all the time. I think patients are often mindful of the precious time, and more patients I see in my non-vulval practice come with lists of medications that they're on. It's so helpful when you get that out, because it just saves so much time. And it's also, part of our good clinical practice, really, that we're mindful of all the treatments that are there, that are currently taken. You don't want to duplicate a treatment. You don't want to give the same treatment again. You don't want to give a drug to a patient who's had who's on another drug where it's contraindicated. So all this information is helpful.
Okay. And Winston, I'm just going to bring you in here. Winston de Mello, consultant in anaesthesia and pain medicine at Wythenshawe Hospital, Manchester University NHS Foundation Trust. You were in that role for 24 years and retired only last year, at which point you came and joined us at the VPS. We're very grateful for that. Is that the same in terms of pain clinics? Is the length of time still 20 minutes, or are they longer appointments at pain clinics?
Well, we're very lucky in that we have an hour,
Right.
which is a great luxury. You heard David talk about the importance of making a diagnosis. In the pain clinic, hopefully the diagnosis has been made, and we're there for further management plans from a pain perspective. So just to give you an illustration, in that 1 hour, we have 20 minutes where the patient has got 20 minutes to tell us all they want to tell us. We've got 20 minutes for an examination, usually done by Fiona Hart, my specialist physiotherapy colleague, because most patients with vulval pain will have pelvic floor dysfunction. And then we have a further 20 minutes using a whiteboard where we summarize all the points and come up with a plan. The reason for the whiteboard is that the patient can take their phone and photograph it, so they've got a record of what we've said. Later on in the day, in the evening, it'll probably take, for a complex case, probably take about an hour to dictate a letter. And quite often, if the consultation is difficult because the patient's very distressed or very upset, you lose a lot of information, which is why we came up with the vulval pain checklist. And it's subtly different from the one that David uses, because we're focusing on pain medicine rather than gynecology. So we have the same sort of aspirations to try and get to know as much as we can about the patient, what they've tried. But we're also interested in function, how it's impacted on their quality of life and their function. And another thing is we try and use a biopsychosocial model, which is a mouthful, but really trying to address psychological and social issues that will also impact on their welfare and allow us to guide further signposting to other places or other specialists or other healthcare professionals. So I think we were lucky in that respect to have an hour. And the checklist is also useful because sometimes patients assume that we'll get electronic records from the GPs or from the referring consultant. When you consider that we're a tertiary referral service, quite often we may see the patient before even the referral, or vice versa. So I think the checklist is a list that's evolved over the last 20 years, and I find it very useful to make it personal and individual for the patient.
Okay, and that checklist we're talking about, you've revised it, refreshed it, put it together, and that is on our website, and we'll put a link up to that later on. A few comments here, really liking the idea of the whiteboard. That does seem like a great idea to take away with you, because often at these appointments you have a lot of information and you might not be taking it all in, and to have that resource is so important. We're going to come back to that checklist in a little while. But David, coming back to you, because really, Winston Pain Clinics, as you say, tertiary service, it comes later on. Ultimately, David, they may be coming to see someone like you or another gynecology clinic first of all. And what might someone expect from that? Who else is in the room with you? Is it just you and the patient? Tell us a little bit about that.
So it'll be a clinic room within a hospital, or it might be a community clinic. Many gynecology clinics are in the community now. So this is following the referral from the GP. It'll be a consultation, sort of good old-fashioned sit down with the doctor, face to face, just as you would expect. That's how things would start, with a hopefully a referral letter. There may be some. What's creeping in now are more doctors are typing directly into a computer. So we don't like this, but many of us don't like it, although GPs have been doing this for years. So you're talking as a patient and the doctor's looking at the computer, tapping away. So that's creeping into more hospitals now. So doctors aren't fans of that generally, because we're losing eye contact, but that might be happening. So the doctor is listening. Doctor should have known about the referral when the patient comes in. The exploration is about the presenting complaint, and as I've said before, we have to nail a diagnosis, and that should be our. This is before you would go to Winston's clinic or other pain services. You're trying to make a diagnosis, and so that's a history, and as Winston says, history, then examination, and summary. It's a bit like that, except it's faster, really. So the examination is optional. I mean, that isn't that as a standard of care. We would examine a woman coming to the clinic because that's part of the service, and I think most women expect to be examined because they want to know what's going on, and they would accept that that's acceptable as part of the visit. Not all women would accept an examination. That's fine. They might want to come back another day. But yes, we would have examined with a chaperone. There's occasionally a junior doctor there. I have a lot of GP trainees who come in. I think they should learn, really, and they're often with the consent of the patient in the room. And there's usually, as I say, a chaperone, a nurse in the room with the patient. And the examination, specifically for the vulval examination, as the vulva is a skin surface, we're looking at an examination of all the skin surfaces. Look in the mouth sometimes. We're looking on the back and the wrists and the hands for clues of skin problems. And then we feel the abdomen, look at the vulva with a light, and then we would might pass a speculum to look at the cervix if necessary. That's not absolutely essential for someone with, for example, the vulval pain problem, and that might not be appropriate the first visit, but that might be part of the whole process. And when we get changed, then there'll be a chat about the findings, and hopefully, as I've mentioned, a diagnosis made and then a plan.
Okay, really important to reach that diagnosis so you know the appropriate treatment route.
So because I think, sorry, Sheren, I mean, so many women come to the vulvodynia clinic that I run, and they're not quite sure what their diagnosis is. So you're already you've already got a sort of lack of understanding on the part of the woman without a diagnosis, and you're trying to treat them as having a vulvodynia problem when they're not quite understanding what their problem is in the first place. So I think that, I think it is important to nail the diagnosis.
Yeah, absolutely. So in the questionnaire, there are some questions that might need a bit of explanation. There's a question there about, have you had problems with your back? Why is that important?
Yeah, so I mean, I think in fairness, this questionnaire is quite long, and there are probably bits that aren't. Well, one size doesn't fit all, and some women might find this questionnaire a little bit too long to complete, and doctors may not look at the whole questionnaire in total. To answer your question about the back problems, we know that many women with vulvodynia or vulval pain syndrome have other pain issues. So there may be issues of chronic pain in other parts of the body. That's not uncommon. And there are links to back problems, sacrum problems, pelvic floor problems that may have been put to one side when in a gynae consultation all the focus is on the vulva. So it's a history about the vulva, the symptoms, and a focus on what creams have been tried, and then a look at the vulva with a very narrow focus of looking at the vulval problem in isolation. So the issue about back pain and that and other symptoms just perhaps opens up the thought processes that, is there something else going on, or is there something linked? Can there be a link between the two? We know dental neuralgia, which many viewers will have heard about, that some of those symptoms are very similar to vulvodynia type symptoms. So there are other pain syndromes in the urogenital anatomical area, i.e. the sort of pelvis and the genital area, that we need to think about as well.
Yeah. And likewise, there are questions about, have you noticed diet aggravating things? And really, it's a checklist to see if there are any potential clues, I imagine. So there's diet, whether you've been free of symptoms at any time, how long you've been free of those symptoms, have you ended a relationship due to your vulval symptoms? I guess all of those questions give you an idea of where to signpost or where someone might need to be going next. Is that right, David?
That's right. And I've had patients fill the questionnaire and felt it's been a very useful process to put on paper their story, their own writing of the story that's the past, that's evolved over time. So in itself, that can be a useful process for some women to do, and we do have links to diet. We do have links to all sorts of things that aggravate and relieve, and it's worth putting that down on paper, because the package of care, the Winston's whiteboard that will be hopefully full and rich at the end of the consultation, there will be medically prescribed treatments, there will be physiotherapy, there will be CBT and the biopsychosocial model. But for some women, there will be diet as a part of the package. Certain things will make vulval pain worse, and certain things that, when avoided, will make things better. And as medics, we don't have all the answers to these things, but it's a truth that for some women that will be part of their plan, avoidance of certain foods. We can't explain all these questions, but it's on the questionnaire just to make that link. There's a very old work on oxalate diets, which we've really probably moved away from in the last sort of 15 years. But we remember it, and we remember the diet pain issue.
Yeah, and I think at some point on one of these lives, we'll probably get a dietitian on to talk about maybe the gut microbiome. That's one for a future live stream. So Winston and David, you both talk about the importance of having goals. Winston, do you want to talk to us? Look, isn't the goal that people just want to be pain-free, right? When you say what's your goal, what do you mean?
Well, I just want to clarify the assumption that that most patients can be pain-free. Chronic pain is a chronic disease like high blood pressure, asthma, etc. So occasionally patients will get very good pain relief, but I have to give you sort of the background that a 30% improvement in your pain is regarded as a good start. And this is why we go for multimodal approaches to getting pain relief. In other words, the role of drugs or injections are just part and parcel of a bigger package.
Mm-hmm.
Now, if you've got chronic pain or a chronic disease, it obviously impacts your function. And if it impacts your function, it impacts on your quality of life. So each patient that comes to us, I find it useful getting an idea as to what that patient wants to achieve in the next 5, 10, 15 years. The reason for that is then the focus can be on achieving that ambition, aspiration, and I guess we as the team then provide them with the support to get there. In other words, realistic functional improvements over a period of time. So I think function is just as important as pain relief because, as I've alluded to, most patients will still have some background pain, and it's important that we make sure that our treatments don't impact on function.
Okay. So when you talk about realistic functional improvements, can you give us an example of what you mean by that?
For example, it could be an 18-year-old girl that wants to go to university. Well, that's pretty easy to measure because you know that you've got to get certain grades in A level and apply to university for a place and then hopefully succeed. But if you're having problems with a chronic health problem like vulvodynia and it's intrusive, then we've got to find strategies as to how that work or that task is broken down into smaller chunks and a way of life around it so that the patient can achieve their end goals. So it's just really trying to provide some motivational interviewing, trying to sort of make it something that can be measured so that, yes, you've got to university, yes, you've completed your degree, or yes, you've been able to have less painful sexual intercourse, yes, you've managed to get pregnant, yes, how do we manage your delivery of your baby? It's those kind of essential functional events that we're trying to support the patient with. And they'll vary from patient to patient.
And we've had a question here. How do you get a referral to a pain clinic?
First of all, there are several types of pain clinics. The general pain clinic would obviously be the first port of call, but there are increasing number of pelvic pain clinics around the countryside. There are some in London, Bristol, Manchester, Liverpool, Edinburgh, and the numbers are increasing. And then most of our referrals were coming from other hospital consultants, like David in gynecology, dermatology, or urogynecology or coloproctology. So most of our referrals were tertiary. So it's a consultant to consultant referral. and then a few GPs might know of our service and refer directly. So it's a mix.
Okay. So I hope that's answered the question for the person viewing at the moment. This checklist that's been put together, that's on the VPS website, how's this evolved? You know, you've put 11 points together. How has this come together and evolved?
We initially used the International Pelvic Pain Society questionnaire, which is very American and requires a lot of information, which probably would be more beneficial for for somebody like David, who, the gynecologist. But from a pain point of view, for example, David mentioned about looking at the back. One of the things we want to exclude with a bad back is Main syndrome, which is basically stiffness between the ribs, the vertebra between your ribs and your lower lumbar vertebra. Now, that's very popular in France, but it's not as popular in the UK. So when we're examining the back, we're trying to exclude that as a cause of pelvic pain. But the other issue is that patients with vulvodynia will usually have one or more pain syndromes all over the body: IBS, fatigue, headaches, palpitations, bladder pain. The list goes on and on. And I think it's important from our perspective to get an idea as to what other pain problems there are, because say, for example, you've got IBS and you tend to get constipated, and you've got vulvodynia, and I was hoping to start you on amitriptyline, well, that will make your constipation worse. So, in other words, I really need to know the whole person before picking out what I think might be the best guess, because at the end of the day, all the treatments are trials of efficacy. So I think it's so our checklist has evolved over time. It means that first 20 minutes with my patient, I can concentrate on what the patient wants, because she's already written it on the paper, what she wants and what she wants to know, what she wants to get out of the consultation. So everything becomes focused, because all the other information that I require as the physician is already on the checklist. So it makes my task a lot easier, but it also makes it, I think, more productive for the patient to walk out, hopefully, with what they wanted from it. And for those that are not sure, it's a very intrusive amount of questions, very personal questions. But I do think it's important to really identify what is going on in that patient's journey so far, so that we don't repeat the same mistakes. So that's
Yeah.
how it has evolved.
Yeah. And so, yeah, we've got 11 points on there. Can you take us through maybe a couple, 2 or 3 of those points that you think?
I think I'll go for the first one, the reason for the referral, because it may sound very obvious to you why you're coming to the pain clinic, but it is not always so. It may be that you were sent to us directly because the GP felt that we might be able to confirm a possible diagnosis, like pudendal neuralgia. Or it might be to exclude another pain problem. Or it may just be to see Fiona, my specialist physiotherapy colleague, who is very different from women's health physiotherapy, and or whether they're suitable for an intervention. So I think when I say the reason for the referral, I'm really want the patient to be sure that they know why they're coming. For example, if the patient was sent to me to exclude pudendal neuropathy, that's all I'm going to do, because we're a tertiary referral. I'll send them back to the referring consultant, either confirming I've made the diagnosis and could carry on the management, or exclude it and pass it back on. So I think it's when you're moving around specialist teams, I think you need to be clear that sometimes we cannot take you on, especially if you're not from the local area. If you come from far parts of the country, it may be better to get local treatments.
Okay. So that's the reason for the referral being important. Someone was asking, what clinic is Winston speaking about? We're talking about a multidisciplinary team at a pain clinic, aren't we?
Yes, I mean, and the clinic, which is still running by my colleague, Dr. Viawari, usually consists of my physiotherapy colleague, Fiona, and myself. We occasionally get the specialist nurse in, but because we're a teaching hospital, we have undergrads and postgraduate nurses, doctors, consultants coming in to get their professional development. So the room can be sometimes 3 or 4, but we tend to ask permission of the individual patient if that's okay, just out of courtesy. And I think during the COVID pandemic, we had to do consultations by video conferencing. It was fragmented, as David says. You lose a lot of information by doing things by video, because you can't see the body language, you can't see things as you would in a normal consultation. But it also meant that the patients would have to come again for a face-to-face with Fiona, and then that delays the final diagnosis or management plan even further. So I think COVID has made it more difficult to achieve or continue what we have been doing prior to COVID.
Sheren,
Yes.
just to follow on from what Winston's saying, we're not quite sure in the UK landscape how the teams are working. Some services like Winston will be meeting face to face together. My feeling is that there are other services that are meeting prior to COVID more virtually. So there may be informal sharing within hospitals. The physio, the gynaecologist, the pain specialist, the psychosexual therapists are all individuals who have an interest in women with vulvodynia, and they're not meeting as a face-to-face in one room, but they're sharing patients in terms of cross referral. And I think that's happening more now, where people are communicating with different specialties, and it's sort of becoming multidisciplinary, which is good. And we don't have like a cancer MDT would be a very good example, where people meet every week in one room, all the specialties there. They sign a register. They have to be there in many ways. We're not quite there with chronic genital vulval pain, but we do have those networks sort of forming, as Winston says, more and more services being set up. Winston, do you think there are many clinics where you see a pain specialist, a physio, and a psychosexual therapist in one room?
Very few in the UK. I think it's a luxury. I can think of places like Liverpool, Bristol, Edinburgh, London. These centres will have variations on different configurations of the specialists involved. I think it's an expensive luxury to have everybody in the same room for one patient. I think it's the expense that's really the problem.
And it might not be appropriate to have a 3-hour session where you have a medic, physio, and psychosexual therapy all in one package. For a chronic problem, for the patient to stagger it or prioritize. That's the goals, isn't it? If the goals are prescribed on, in your history, then you deal with the goal, the main goal, don't you?
Someone's asked about dermatology. David, would someone get access to a dermatologist by coming to see you, or how would that happen?
It depends on the diagnosis. So we know that there are a number of skin problems that can cause chronic pain, and there are a number of women with vulvodynia who have a have another problem, like they might have some vulval eczema, dermatitis, itchy inflamed skin, but they may also have vulvodynia. They may be some subtle lichen sclerosis, where there is some splitting of the skin leading to vulval pain, and there are crossovers in some women. So it's back to the diagnosis, isn't it? You know, what is the diagnosis, doctor? Have I got one thing or two things going on? So gynecologists will, in their training, have some expertise in vulval disease. They will be able to take a history, examine the patient, and begin treatment. The commonest things we see in the vulval clinic are vulval dermatitis, lichen sclerosis, and in my clinic, lichen planus. So these are conditions that produce pain and itch, and they're visual conditions. You can largely see the conditions with a good light, and then you start treatment based on the diagnosis. So it may not be necessary to see a dermatologist for that reason. And likewise, a dermatologist would be, for example, able to prescribe vaginal estrogen pessaries for someone who's gone through the menopause, where there'd be dryness, and you might think that was something for a gynecologist. So there's a little blurring of the roles and responsibilities here, but both specialists tend to get that basic training. You might want to see a dermatologist if you've got or at least a vulval specialist who's interested in a dermatologist with an interest in vulval disease. If there's something a bit more complicated, perhaps a rare condition, something not so common, or if everything's been tried and you're actually not getting any further with the skin problem you're trying, you don't quite reach your goal, as Winston says, then you might want to see a dermatologist. But not all dermatologists have an interest in vulval disease. I think that's fair to say. Not all gynecologists have an interest in vulval disease. So we're led by specialties in medicine, but in many ways we're driven by our own individual interest in patients and our own areas of expertise, and that's probably cross specialty, really.
Someone mentions dermatologists may try immunosuppressants too. What we'll do is probably bring in a dermatologist in one of these social media lives in the future. So in-depth questions about dermatology can go to them. We do have existing videos on our YouTube channel, and you'll find Dr. Liz Venner, consultant dermatologist, specialist vulval dermatologist. One of the videos she'll be answering some of those questions. So perhaps after this live today, or at your own convenience, checking out our YouTube channel and seeing some of the questions that you have may have already been answered. If you do put a question up in the comments box and we don't answer it, it could be that it's too personal to you, and feel free to reach out to us.
info@vulvalpainsociety.org.uk.
And we'll see whether we can help you. But it might be that one of those videos that we have on the Vulval Pain Society YouTube channel answers your question. And we're going to have more of these social media lives. Winston, can I ask, you mentioned that you want the patient perhaps not only to put down their experience, but also how it impacts their family, maybe their friends, their quality of life. Tell us a little bit more about why that's important.
Well, I think the traditional model of just taking a history, doing an examination, ordering some investigations, and making a diagnosis, which is a biomedical model, has now really changed to a biopsychosocial model. And the best of this is run by Dr. Stannard in Gloucestershire. I think we in the pain specialty have to sort of accept that a patient's family background, the way they've been brought up, all impacts. And the World Health Organization recently started looking at the impact of, for example, childhood events on adulthood and future healthcare. And it was quite revealing that, and that's one of the reasons why in number 6 in my checklist, I've asked, is there a family history and are there any problems during your childhood, which is just really to try and tease out uh, what those issues were, because
Mm.
you don't have to know it in great detail, but at least it gives you some idea. Now, you'd be surprised, perhaps not, but when I looked into it, it is regarded the majority of us have at least one adverse childhood event, the
Mm.
majority of us. But when it gets to 4, the impact on their health, both physical and mental, is huge, huge.
Mm.
So from a I guess from a holistic approach, I think it's really important to know what the patient's gone through,
Mm.
because if you can provide support, provide empathy, and try and tease out what can be changed and what cannot be changed, I think it goes a long way. And at a meeting recently, one of the consultants said they wouldn't really get involved because it was like opening Pandora's box. And another, there was a psychiatrist in the audience, and he turned around and said, "Do you know what was at the bottom of Pandora's box?" Well, my knowledge on that was minimal, but he said it was hope. And I think when you can acknowledge somebody's journey, you're not going to change it, but at least you can give them some sort of empathy and acknowledgement of what they've gone through. And I think that, and that builds up trust between you and your patient, that therapeutic relationship. And one of the advantages of having a specialist nurse, because it doesn't have to be the doctor, it could be the physio, it could be the specialist nurse. But in my experience, it's been my secretary, because they'll get a phone call. They can tell by the tone of the voice, the urgency of or the distress that is being done, and then I can get a quick message and abort a problem quickly rather than waiting for them to come to the next appointment. So I think the most important person for me to run a service is the secretary, and I think that's if you've got a good secretary, you're laughing, because they're invaluable, because they can almost prevent a bad situation getting worse just because of lack of contact. So I think it just depends on who you've got in your team to be able to provide that
Mm.
sort of all-round care.
Mm. Um, so in this 11-point plan, these points that you have to prepare, you end with 3 questions that the patient wishes to specifically have answered. So that's at the end of the consultation. What's the basis for this?
This was something that the NHS tried to bring in a few years ago. The theme is shared decision making, where you
Mm.
discuss the options with your patient, and then they choose what they would like to undertake rather
Mm.
than what I feel they should undertake. So you provide them with the information, they make the choices, and I find that is better because one of my patients, Fiona by name, who I contacted in preparation for today, and I said to her, have a look at the checklist and tell me from your experience. She's in her mid-30s, but she had a problem from childhood with pain. And she said, I just want the doctor to tell me to be honest about how I really feel. And in particular, the distress, emotional distress, and the hopelessness that they feel. And I think that is really good, that a patient can put that down on paper, because at the end of the day, that's what's probably going to cause them more anxiety and distress once they've left the consultation, as to my feeling that an injection is going to sort their problem out, which is not always the case.
Yeah. It's being heard, isn't it? And that's so important. Marion from
Yes, just being acknowledged, and
Marion from Pudendal Neuralgia says the same. Information and interaction is invaluable to the patient and consultant, and it is a partnership, isn't it? Yeah. So to think about wrapping up now, if you could perhaps recommend or suggest one or two things that people could go away from this social media live, and think about, if you're watching, you might have some action points that you're jotting down, but what might be really important things for someone to do to prepare or do whilst they're there at an appointment? So just one or two things. David, I'll start with you.
I would try and get I would try and be clear on the diagnosis. If you have the diagnosis and you're confident in that diagnosis and you believe that to be true, I think that's very important, because then it is more likely that you would engage with a treatment plan. And if you don't have the diagnosis, then you've got uncertainty, which comes back to your question about, I need to see a dermatologist, because when I thought about the question you asked, I think people want to see a dermatologist perhaps because they believe that the doctor didn't look properly or look with the right light, and they might have missed something. So I think that's important, to be confident in the diagnosis. That's probably the first thing. And then I actually prefer Winston's 11 questions really as a framework. And as a medic scanning that form, if the nursing auxiliary came through prior to the patient coming in, the nursing auxiliary gave me the form and said, "This is the patient's filled this questionnaire for you." It would be a very good framework, I think, to work through. Speaking from an average doctor working in a busy clinic, the questions, and I think that would be really helpful to think about the form, just completing it, and it might really focus the consultation, because these sessions are very precious. So I think the form should get the diagnosis, and if you don't have the diagnosis, ask for one. If the doctor can't give you a diagnosis, then I think you might have to consider a second opinion, which is totally reasonable. It might not be in that individual's expertise. They might refer on. And if you've got the diagnosis, then fill in Winston's questionnaire, or at least work through it and think about the issues that are quite holistic when it comes to chronic pain. That was two sort of things, isn't it? But
yeah,
plowed out.
Winston, before I come on to you, there's a few people here from Scotland wondering how, whether they can get a referral. Someone's asked, can I get a cross-board referral from Scotland? And yeah, other reports about experiences in Scotland. How does that work? Is there any kind of joined up way of doing that?
Well, first of all, I should make people aware that there is a service, I think, at the Western General in Edinburgh. And I think that the name of the surgeon is Mr. Brown. Don't quote me on it. But we do accept referrals directly to the pain clinic at Wythenshawe. where my colleague, Dr. Viari, would take over their care. So we do get referrals from Scotland, Northern Ireland, Wales, and occasionally the Isle of Man.
Okay. Someone is asking about, should we be taking our own list if we aren't sent one? Well, I'm not sure that lists are sent out, but you can access our checklist on the Vulval Pain Society website, and we'll post the link up shortly. So yeah, we'll pop that into the comments so that you can access that. So the 11.1 is a good one to go through. If you haven't yet got a diagnosis, maybe the longer one, just to jot everything down. But those links will be in the comments. Any final points to mention, Winston? Perhaps, one action point or the most important thing to do, something to wrap up.
I think that the best advice I can give these patients is if you're going to a pelvic pain clinic, use the checklist to do an MOT on yourself, to really identify how the vulval pain is impacting you in a global sense, because that will focus you on and give you a realistic summary of what is going on. Now, if you've got a good MOT, the chances are that you can fix some of the things in the consultation. So for me, the checklist is only a skeleton on which you can start applying some flesh to get a better, or like a jigsaw puzzle, where you just put more and more pieces on so that you can see the bigger picture, both for the patient and as well as for the physician.
Anything else to mention, David? Anything else you want to mention?
I think that's a really good summary of going forward, really. And back to what Winston said in the beginning, thinking this through during this webinar, the consequences of treatment, the one thing leading to another, and Winston, item 4, other areas of pain, bladder, constipation, and other issues. They can be all interlinked without realizing it. Yeah.
Okay. So as we wrap up now, I guess, just a big thank you for those of you who have joined us today live, and those of you who are watching the replay. Before I tell you what's coming up, a few people have asked, they've been in contact, asking how to donate, as we are a charity. And there are lots of ways. There are, you can simply donate through PayPal, and there are details on the Vulval Pain Society website.
vulvalpainsociety.org.uk.
There are more interesting ways. If you shop on eBay and you pay by PayPal, you can add a donation. I think there are some other ways too. Or Amazon Smile. If you have us, the Vulval Pain Society, as your chosen charity, then with qualifying purchases, Amazon will make a donation. So I think Kay Thomas, who's been in the background today on Facebook watching along with everyone who's watching live, will pop up a Amazon Smile link if you'd like to link up your Amazon account to our charity. And as I say, Amazon make the donation. So let me tell you what's coming up. Physiotherapy is a rather broad area. We've kind of touched upon it, physios being part of a multidisciplinary team, and there's a lot to cover. So we've got 2 brilliant physios coming up in the next month. 7 p.m. on Wednesday, the 10th of March, we have Maria Elliott, chartered physio, and also a clinical Pilates instructor. She works with experts in the field of biomechanics, urology, gynecology, pain management, and functional rehab, and she provides an integrated recovery program. So that will be on Wednesday, the 10th of March at 7 p.m. Now, next time, Vulval Pain Social Media Live number 3, the next time is Maeve Whelan. That's Wednesday, the 24th of February at 7 p.m. Absolutely pop this in your diary. I saw Maeve at the Pelvic Raw conference. Shout out to Pelvic Raw, brilliant conference for clinicians. I was blown away by the amount of knowledge and what Maeve was able to share. I've actually heard Maeve Whelan's name repeatedly over the years, both from patients who've seen her and from healthcare professionals. So more details on what specifically Maeve will be covering. If you like our Facebook page, you'll see when a notification comes up, or follow us on Twitter. Our handle is @VulvalPainVPS. Just after we wrap up, there'll be just those details on screen, so you can capture them. So that's us on Facebook and on Twitter, and you can watch these lives again on Facebook and on our YouTube channel. And on our YouTube channel, you'll find a whole host of other videos as well from other experts. So that's all for tonight. Thank you all for joining us. I think a goodbye from all of us. Say bye, Winston and David.
Goodbye.
Good night.
And you'll find the links to those questionnaires in the comments if you're on Facebook, and if you're on YouTube, it'll be in the description field. Check out our website,
vulvalpainsociety.org.uk.
There are lots of resources on there, and you'll find the 2 questionnaires we've mentioned today. You can reach out to us on social media or email us at
info@vulvalpainsociety.org.uk.
So that's it from us today. I hope you can join me and Maeve Whelan 7 p.m. Wednesday, the 24th of February. Bye for now.